a little different for everyone. As we go on with our busy lives, we sometimes forget that our body needs time to rest and replenish. From the moment we open our eyes, our mind and consciousness goes into full gear. Whether it is in the classroom in school or the study room at home, we all need sufficient energy and nutrition for continual growth. For some of us, the day will look like morning tea with newspaper, followed by gardening. Whatever the day looks like, we all need sufficient energy to carry it out and the right nutrition for continual growth. For 10,000 days, we have been focused on one thing, by providing continuous professional support so you can achieve your healthy lifestyle goals. Milestones are not just numbers. We hope we could reach more milestones together because we care from day one. Caring will always care for you.
Hello, everyone. Thank you so much for tuning into our live stream today. Today is a cool Thursday night. My name is Dilhara. I'm a caring pharmacist and your host for today. So, how has everyone been doing? I know my battery is all powered up. I just had a very delicious dinner, and I hope you had a delicious dinner too. If you're watching this right now, don't be shy. Say hi. Hello, Aries Cool. Hello, Tan. Hello, Lam. Nice to meet you all. Okay, do let me know where you're tuning in from as well. I'm actually right now near Paradigm Mall. Today we're going to talk about a special type of diabetes, the type that only occurs in pregnant women. Hint, you could still get it. It could still happen even if you don't have a previous history of diabetes. Let's see if you can take a wild guess as to what it is. Comment below if you know what is the name of this type of diabetes. Another hint, it's in the title. But if you are unaware of what it is, that's why we have this very interesting session tonight. But here's a thumbs up for those of you who have guessed it right. Today we'll explore the basics of Gestational Diabetes Mellitus, also known as GDM. Hello, Elena Chan. Okay. If you think you know someone who definitely needs to be here right now, quick, alert them right now because tonight our subject matter expert is a consultant physician and endocrinologist from Hospital Putrajaya. She has had extensive research and working experience in management of GDM, Gestational Diabetes Mellitus. So, without further ado, to discuss and help us better understand diabetes in pregnancy, let's welcome our honorable guest of today, Dr. Masni Binti Mohamad. Please come in, Dr. Masni.
Hi, thanks Dilhara. Hello everyone. I'm Dr. Masni from Hospital Putrajaya.
Hello, Dr.
Hope
Masni.
everyone are okay.
I'm good. Are you okay?
Good. I'm
Such
good.
a it's such a pleasure having you today. I hope you
Yep.
had dinner. Have you been doing
Yes.
well?
Yep.
Okay, great. Actually, I was just asking the audience whether or not they are aware of this type of diabetes that only occurs in pregnant women. So actually, in the pharmacy, it's not uncommon to find young women purchasing blood glucose monitors. These women also come to the pharmacy counter. They require advice on diabetes management for GDM. And then we end up talking about dietary changes, physical exercise, blood glucose self monitoring, and target glucose levels for these GDM patients. So, for our lovely audience today, Dr. Masni, let's start with a smooth introduction to GDM, Gestational Diabetes Mellitus, what it is, and how it is different from general diabetes.
Thanks Dilhara. Before I go on, zoom into gestational diabetes mellitus, just let me touch a bit on diabetes in pregnancy.
Yes.
Diabetes in pregnancy is a state where there's high blood glucose during pregnancy, as the name implies. Yeah? Right? So it's divided into two. So either you are already diabetic, type 1 or type 2 prior to pregnancy. So that's diabetes in pregnancy itself. Or during pregnancy, you develop high blood glucose. So that is also diabetes in pregnancy, but that is under the umbrella of diabetes in pregnancy, but under it is gestational diabetes mellitus. So after delivered, so usually this diabetes resolve. Yeah, resolve. So that's gestational diabetes mellitus. Dilhara, back to you.
Thank you so much for that very brief introduction on GDM. I myself, I myself understand it a little bit more better now. Okay, so now we would like to move on to the definition of gestational diabetes, what it entails, and a little bit more on the intro on GDM.
As I mentioned, any high blood glucose or hyperglycemia during pregnancy. So all patients could be having pre-existing already. They did not know that they're diabetic. So during pregnancy, then they notice, because pregnancy is a state that we will always see patient review frequently. Mainly because of the maternal taking care of the mother, taking care of the fetus. So because of that frequent reviewing, so the screening of high blood glucose is being done during pregnancy. The detection of high blood glucose during pregnancy at the first trimester is usually associated with pre-existing diabetes. Yeah, pre-existing. So pre-existing diabetes, it can be due to type 1 or type 2, but it can be the diabetes developed during the first trimester itself, could be. It can be gestational diabetes mellitus also. Yeah,
Okay.
but GDM, or gestational diabetes mellitus, usually developed at 20 to 24 weeks and above, usually. Yeah, usually.
Okay, thank you so much for defining GDM for us. For those watching, we'd like to gauge your understanding in gestational diabetes as well. So, for those who are watching and who understand a little bit more, what do you understand about GDM? You can comment on the comment box for those who have someone who had experienced it, or for those who have experienced it themselves. You can also comment on your experiences in the comment box below. For those who's just joined us in this live stream today, thank you so much. Again, today we have Dr. Masni, consultant physician and endocrinologist from Hospital Putrajaya. She's enlightening us on the management of GDM, gestational diabetes. So, before we proceed deeper, be sure to stay tuned until the end of this live stream, because we will be having 2 rounds of giveaways. Yes, I said it. That's 2. That's 1 more than the last time.
Yeah,
A
2
total,
rounds, yeah?
yeah, 2 rounds. That's the total of 8 lucky winners, you know. So call up your friends, call up your family, and ask them to join this live stream now. I already see a bunch of questions in the chat box. Don't worry, we won't be attending to it now, but we will be attending to it at the end of this session. Okay.
One of the prizes will be glucometer, right, Dilhara?
Yes. Oh no, not just
Yes.
one. 5
5,
glucometers.
yes.
Yeah.
That will be good because we are talking about hyper blood glucose in pregnancy. So it will be good.
Yeah, definitely.
Mm-mm.
So, now we'd like to know what GDM is. I have a question for the audience. Actually, it's not a question, it's a poll. So the poll will be posted right now. The poll asks who among us is possibly at risk of GDM. Can we have the poll up, please? We are going to be running a poll. Our good doctor has gone through briefly just now on the risks of GDM. If you understand, let us know in the poll below.
All right.
Okay.
So who are at risk? So just put it up. Yeah. Who are at risk for GDM?
Can we have the slides as well? Okay, in the meantime, I would like to remind our lovely people of the floor that there are 2 giveaways later for 8 lucky winners. We are, as Dr. Masni mentioned just now, we are giving away 5 OneTouch Select Plus Simple Glucose Meters for question number 1. And the second question will be giving out free 50 ringgit CARiNG Cash Vouchers. And this will be for question number 2. So stay tuned, keep your ear out, and the answers will be revealed in this session shortly. Okay, so let's roll back to our main agenda. Allow me to pick your brain, Dr. Masni, with one very important question. If a pregnant woman is at risk of GDM, when should they screen for it? And also, you could maybe tell us what the screening is like.
Before I proceed to the screening, so probably I just put up the answer from the poll just now. So who are at risk? Yeah, who are at risk? I'm sure the audience wants to know the answer. So there are many people. There are many. How about put the points that make you at risk to get GDM? So it's not just one reason, yeah, one cause. So being overweight or obese. So 27 kilogram per meter square is an obese range for Asian, yeah, for Asian. So being obese put you high risk for getting diabetes during pregnancy, gestational. Past history of GDM definitely put you at risk for a second diabetes in pregnancy during the second pregnancy or subsequent pregnancy. Okay. First degree relative, your parents or your sisters or your brother is diabetic, so you are definitely high risk of getting GDM also during pregnancy. History of maybe your first baby or second baby is your big babies with a weight of 4 kilogram and above. So that pregnancy is likely that you already developed diabetes during pregnancy and subsequent pregnancy, high risk of GDM. So bad obstetric history. So what do I mean by bad obstetric history? History of your fetal died during pregnancy, baby born with birth defect, yeah, or any baby developed shoulder injury during pregnancy. Yeah, so that is bad obstetric history. Having that history, that may suggest you for getting a GDM in your pregnancy, yeah, next pregnancy. Urine, having glucose in urine, that urine is not just 1+, 2+, that put you a higher risk of getting GDM during that pregnancy and subsequent also. Current problem of obstetric issues such as having pregnancy-induced hypertension or preeclampsia, they call it, when they involve organ problem. During that pregnancy, you have a lot of too much water in the womb. So that is likely that you're having GDM also. Okay, so the doctor should be doing the screening when you have all those risks. So all those 7 risks put you so the doctor will with those who are at risk, with all those 7 risks, the doctor will screen you. Yeah, they will definitely screen you early as possible. When your UPT is really positive at about 8 weeks, so they have to screen you if you have all those risks. Yeah. Okay. So what are the screening? The next slide will show you how to screen. So at early when you are positive, your UPT is positive, so you will definitely go to your GP or to your clinic kesihatan for a first booking. Yeah, for your first booking. So it can be at period of gestation at about 8 weeks or maybe 10 weeks. So when you do your first booking, knowing your risk, your doctor will automatically screen you. Yeah, will screen you at first visit itself. Okay, here's as shown in the slide. So those are at risk. Okay, if let's say they are not at risk at all, no, those 7 risks are not there. So if you are 25 years and above, so they will screen you at 24 week and above, right? So these are the two reasons that they will screen you. Those are at high risk and also age 25 and above. So if looking at those, most Malaysian expecting mothers will be doing the screening. Yeah, so it will be like a universal screen, because most of the mothers, unless it's teenagers pregnancy lah, okay, most of the mothers now, they tend to get pregnant a bit late, so more than 25 years old. If let's say you are not high risk, they will screen you because of your age. Otherwise, if you are at high risk, your screen will be you will be start screen. Yeah, the screen will be started. So how to screen? By doing an oral glucose tolerance test. Yeah. So the OGTT, if let's say the results is at fasting is more than 5.1, or 2 hours is more than 7.8. So if positive, confirm you are GDM already. If no, your sugar is at fasting is about 4.8. So 2 hours after drinking the glucose, your glucose is about 6.1. So you are not GDM. But that has to be repeated at 24 weeks to 28 weeks, right? So if at 24 weeks, the repeated oral glucose showed high at fasting, more than 6 or more than 8, yeah, so you are diabetic, you are definitely GDM. Because, right? Okay, so is that
That's
understood?
absolutely very clear. The OGTT result, I would just like to clarify to the audience that this is the one that you go to the clinic, they make you drink like a small amount of sugar, and then 2 hours later, they take another reading. Am I right, Dr. Masni?
Yep. So
Yes.
you make it sound as a small amount of glucose of sugar. Actually, it's not really
High
small.
concentration.
75, very concentrated. Can you show the next slide, please? How to do the OGTT. The
Yes, here we
OGTT,
are.
oral glucose tolerance test, you have to be fasted about 8 hours minimum. It can be 10 hours, but minimum 8 hours. So come to the hospital or come to the clinic kesihatan or go to your GP. So they take your blood at fasting. Then you have to drink the oral the glucose, which is mixed about 75 gram. It has to be 75 gram. So to mix it with water, usually this glucose is already flavored, orange flavored, so it will taste better. Okay, so drink within 5 to 10 minutes. You cannot take on sweet time. Yeah, within 30 minutes. No, it has to be drink within 5 to 10 minutes. Then take the blood 1 hour after and 2 hours after. Right? If you vomit out the glucose again, it has to be repeated the next day, not immediately. Okay, so the results is to be taken prior, which is fasting, and 2 hours after. We interpret the results 2 hours after. If the results are more than 7.8, so you definitely GDM. If the results more than 5.1, so definitely GDM. Okay, right?
Understood, loud and clear.
Okay.
Just to remind everyone that this will be done at the clinical setting. This is be done at the hospital. Don't worry about preparing yourself at home. All you need to do is fast. So this is a very effective screening method to screen for GDM. And it's a very common screening method as well in normal diabetes. Okay. So simple, non-invasive screening test, yet so valuable in determining your health outcomes. Now, my question to you guys, how many of you have already screened for GDM just like this? Please comment and share your experience at the comment box below.
Yeah.
Yeah, I'm sure there
Share
are
the
many
experience of
experiences.
drinking that glucose.
Yeah, and taking your blood samples
Yep.
twice, some more. If you're watching this and if you're wondering if you or someone else you care for should get screened for gestational diabetes, don't hesitate to ask your healthcare professional. I'm sure that some viewers who are still not aware about the dangers of GDM and the importance of screening up until now. So thank you so much, Dr. Masni, for explaining that very clearly to us. And this is also why it's extremely important to raise awareness, like what we're doing today. Speaking of awareness, Dr. Masni, we are moving on to our next question, which is, why do you think people, especially pregnant women or those who are planning to conceive, why do you think they should be aware of GDM, of gestational diabetes?
They should check and they should be aware of this GDM, yeah, mainly for these two reasons, because of the morbidity and complications of this GDM doing to the mother and to the fetus that they are to the baby that they are carrying, yeah. Okay, the complications are many, so we concentrate on the mother first, and the subsequent slide I'll be talking on the fetus, yeah. So that's the reason why we have to screen and treat, yeah, right?
Okay, so we raise awareness to prevent the complications of GDM. GDM is just something that that happens during diabetes, but the complications comes beyond that. Am I right? Yes.
Yeah.
So
talking about complications, yeah, Dilhara.
Yeah.
Okay. If someone who is diabetic already, be it type 1 or being type 2,
Yep.
outside pregnancy, I'm talking about outside pregnancy. So the complications are long-term. Mainly we're talking about the complication long-term to the patient itself. So there are many complications. So we are talking about diabetes outside pregnancy. The kidney, the nerve, yeah, to the heart, to the brain. So these are long-term complications. So when we're talking about diabetes during pregnancy, two lives are involved, the mother and also to the fetus. And it's within that short period of 9 months, many complications can happen. So the control has to be very tight, and the monitoring also has to be very tight, and usually it's multidisciplinary. What do I mean by multidisciplinary? So it can involve the obstetrician, involve the dietitian, involve the diabetic educator, nurse educator, and also involve the physician or stroke endocrinologist. Yeah, okay, multidisciplinary, tight, very tight level control. The sugar has to be tightly controlled and monitored. Okay, all right. So I just want to stress that point. Within that 9 months, you have to be monitored. Sugar has to be good. Yeah. Okay.
So we've
because
spoken
of the
so
complications.
much. Yes, we've spoken so much about involving complications post GDM, post delivery. So I'm sure you've got a lot to explain about complications. I just want to know more what exactly these complications are, and we've got a couple of questions requesting on that as well.
Okay, so can we put up the slides again?
What are these complications?
This is the one that I put up here is the complications to the mother, to the mom. Yeah. Okay. During the early pregnancy and the whole course of pregnancy, they are diabetic, but at the same time, they are high risk of getting hypertension during pregnancy. So it goes hand in hand, yeah, diabetic and hypertension during pregnancy. So they can getting hypertension, diabetic itself is a problem. So they are also high risk of getting hypertension in pregnancy. Hypertension pregnancy is another headache. It's another headache to manage, because they can get preeclampsia. What is preeclampsia? Yeah, hypertension causing organ damage, mother's organ. Yeah. So if let's say it involves the organ damage, that is preeclampsia. Okay, hypertension causing the organ damage. So that's preeclampsia, right? So having hypertension, preeclampsia, too much water in the womb, we call it polyhydramnios. Okay, you will be seeing mothers who abdomen so extended, so much water in the womb. That's polyhydramnios. Complication from uncontrolled diabetes during pregnancy. Okay, high risk mother getting urinary tract infection, right? Preterm labor, they deliver early, right? Having GDM in pregnancy. Diabetes complications, if let's say they are already diabetic prior to pregnancy, their complications with the eye will get worse during pregnancy. Everything get
eye?
worse during pregnancy. Yes.
Oh, okay.
Everything get worse. Kidney also get worse during pregnancy if they have already kidney impairment during pregnancy, prior to pregnancy. They are high risk also getting ketoacidosis. Acid is slightly higher, yeah, having high sugar, high acid. So that's DKA. Okay, that's the complication that they can get during the pregnancy itself. During labor, okay, they most of the time they need to be induced. They have to be delivered at 38 weeks. If they refuse or they kata no, I don't want to delivered at 38 weeks, higher risk of fetal dying after 39 or 40 weeks of pregnancy. Yeah? Higher risk of cesarean section, higher risk of labor complications, yeah, because of the baby may be a bit big. So shoulder dystocia. Shoulder dystocia is the baby shoulder injury because of the birth trauma. They have difficulty during vaginal delivery, so the baby get paralysis of the shoulder.
Oh, goodness.
Postpartum, so high risk of you getting another GDM, second or third pregnancy or the fourth pregnancy, you become diabetic. So one of the questions just now I saw, so do they have to check after delivery? Yes, and yes, and yes. 6 weeks after delivery, you need to check your sugar. 6 weeks after, please remember, I know you dalam pantang. You have to check, yeah, because you want to know whether you're diabetic or not. Because high risk, 50% of this diabetic mother, 50% will become diabetic in 5 years. Just remember the rule of 5. 50%. These GDM mothers at 5 years will get diabetic. Type 2 diabetes, meaning permanent diabetes. Okay?
50%.
So that's okay. Keep that in mind. So please check. Please monitor. Please do routine screening after delivery. Okay, so that's the complications for mama. So complications for the baby. Many, if let's say they don't know that they are diabetic, so during pregnancy they become they become aware that they're diabetic at POA period at 8 weeks of pregnancy. Okay, so and the sugar is high. So these are the period of when the baby organ are developing. Yeah, organogenesis we call it. Organogenesis, the organ, the thyroid, the heart, the liver, the guts are being developed within the critical period of 8 weeks. Yeah, so that period, if let's say your sugar is high, that is really high risk of the defect in the organ, like a congenital heart problem, right? The spine defect, we call it spina bifida, right? Even the bladder problems. Okay, so that period is very important. That's the reason why, if you know that you are overweight, please do routine diabetic screen. Okay, so that's congenital abnormality, high risk. Neonatal complications, premature, when they will develop perinatal asphyxia, meaning lack of oxygen during delivery, because of their big size. They have lung immaturity of the lung in GDM mothers. The baby's lung is somehow immature, so they develop, after deliver, the baby develop respiratory distress syndrome. So you will notice that a lot of time, these babies of GDM mothers, they have to be monitored in ICU once delivered. They have to, no matter what. Okay. The other neonatal complications, low blood sugar. Once delivered, they develop low blood sugar. During in the womb, the sugar tend to be normal, but after delivery, sugar tend to be on the low side. A baby died in utero, stillbirth. That is another risk. Once delivered, baby tend to get polycythemia. Polycythemia is red cells, high red cells. So the blood tend to be very thick, viscous. Jaundice, yellowish, the baby yellow, the baby become yellow. Enlarged and impaired heart, the baby's heart tend to be impaired. Low iron, delayed fetal development. If long term, you are only GDM. The mama is only GDM. The baby is high risk of getting type 2 also. Type 2 diabetic, type 1 diabetic, high risk of obesity also in the mother of GDM, the baby, and high risk of getting hypertension, future, this cholesterol problem. So we call that as metabolic syndrome. So ladies, expecting or future mothers, please prevent yourself from getting all this. Dilhara, back to you.
Dr. Masni, I'm looking at the chats right now, and a lot of them are like giving this emoji. I'm sure not many had known about
Aware.
this before. You have laid out so many complications of GDM. It just scares me into ensuring that when I get pregnant later, I'm definitely going to take care of myself. And I'm sure this is the same effect you had given the audience as well. So thank you so much for that. How many of you guys, the audience right here, how many of you thought that the only complications of GDM was just that the mother will get type 2 diabetes after that? I'm sure there are some who thought like that. So I'm so glad that Dr. Masni today had shared with us her insightful knowledge on these complications. And I hope you guys take some notes. This information is absolutely golden. Also, Dr. Masni, I would like to ask you to give us some good news. After all that complications, after mentioning all the scary, scary complications, there's only one thing we need to do, right? And it's as simple as monitoring our blood glucose levels and keeping it in check. Am I right?
Prevention is the key.
Prevention, that's what we need to hear. So that is the good news. It can be prevented. All the complications that Dr. Masni had mentioned just now can be prevented. All you got to do is listen to your healthcare professionals. They will guide you and will hold your hand through this. Okay. So I think the most anticipated time is here. It's time for our first round of giveaway. After all that, after listening to all that, we would like to give back. So 5 lucky audience will be selected after this live stream session. These 5 lucky audience will win a OneTouch Select Plus Simple glucose monitor. Okay, so 5 monitors will be given out. Do remember that when you comment on your answer later on, once I reveal the question, do remember to like the Caring Pharmacy Facebook page, like and share this live stream, and then tag 3 people with your answer in the comment section. And this increases your chances of winning. So Dr. Masni, are you ready to listen to the golden question today where our audience can win glucose monitors?
Oh, okay. Who has won?
The question is, can pregnant women get diagnosed with gestational diabetes mellitus even without prior history of diabetes? I repeat, can pregnant women get diagnosed with GDM even without prior history of diabetes? If you look at the screen right now, the question is pinned above the comment box. So please answer. We have 5 glucose monitors to give away. Well, look at the comment box.
The answer is simple. Please answer. 5% will win.
Yeah, even I'm feeling competitive. Are you feeling competitive right now? Looking at the comment box, I'm feeling it. So thank you so much for your participation. I see a lot of correct answers in the comment box. Such a lovely audience. Keep them coming, guys. Okay, so for the rest of you, maybe some who have just joined halfway, tonight we are with Dr. Masni. She's a consultant physician and endocrinologist from Hospital Putrajaya. She's taught us so much about gestational diabetes, and thus far, we've talked about what GDM is like. We've talked about the importance of screening, and we've gone through also all the complications of GDM to the mother, as well to the fetus, as well, once the fetus comes out, as well to the baby. Okay, we have also just revealed our first question to the audience for the giveaway of 5 OneTouch Select Plus Simple Glucose Meters. The question is pinned at the comment box. You can still answer it. Answer is very simple. And then wait for the other question. There's one more major giveaway coming soon. Okay, let's pick up from where we left off just now. So we've spoken about GDM so much that maybe some of us fear it, but we know it's preventable. We know it's preventable with healthy lifestyle practices. So Dr. Masni, what would your advice be for women who are looking to prevent gestational diabetes?
All right, so we know those, I put up the slide just now, the 7 points that put you on high risk. These are the high risk group. So one of them, we can't change our the second and third bullet. That history we can change. The third bullet is we can't change our mother, we can't change our sister. So we are stuck with that history. So if we know that we are overweight or obese, then lifestyle change. Change your lifestyle. Cut down your weight. Cut down how to cut down the weight still. Dietary physical activity. Cut down the weight by physical activity and control your calories. Yeah. So reducing the BMI, that can help you to prevent GDM. Yeah. Definitely can help you. Not 100%, but helpful, very helpful. Okay, other history with that, if let's say because of glycosuria, that is during pregnancy itself. So if you can prevent, weight is definitely play a role. Okay, reduce the weight by dietary and physical activity, which I will, the dietary intervention for prevention, getting the weight reduced by 5 to 10% in 6 months if you're not pregnant yet. Okay. Right. Plan your pregnancy. Plan everything. Okay. Next, back to you, Dilhara.
Okay, thank you so much for your wise words right there. So, since you brought up the poll just now, since you brought up the high risk just now, we would like to go back to the poll. So, the earlier question that we raised in the poll is are you at risk for gestational diabetes? And the poll shows that 54% said yes. According to your 7 risks just now you showed us, 54% says yes. 46% said no. So I believe for these 54%, they can learn plenty from your talk today. Okay.
The incidence of GDM of diabetes in pregnancy in Malaysia is about 8.3, 8.2, but it's increasing. 8.8 latest is increasing. Yeah, it's increasing slowly. Because we are definitely 1 in 5 of our population in Malaysia more than 18 years old. 1 in 5 more than 18 years old are diabetic. Yeah, diabetic. 1 in 5. So, but GDM is about 8.8%. Yeah, about 8.8%. Yeah. So that's considered a lot. Yep. It's
okay.
Comparing to other developed countries, we are definitely considered high. Yeah.
So we have so much we can do to prevent, and there's really just prevention to look at.
Yep.
Now, prevention. Time and time again, we hear the phrase, prevention is better than cure. But if prevention cannot be attained, for example, if one finds herself at risk of GDM, Dr. Masni, could you enlighten us on how she could manage GDM? And would be some good lifestyle practices of GDM management, would it be helpful?
Yep.
Maybe we can show some slides.
Once you're pregnant, then you screen yourself because you are high risk and confirm that you have GDM already. Okay, so once you're GDM, these are the things that we have to teach the mother. Okay, we'll do it in a group. Okay, we taught about medical nutrition. What is medical nutrition? Is the dietary intake. What are they supposed to eat? Yeah, what are supposed to avoid? Yeah, okay. So that dietary intake play a big role. Yeah, okay. Because before we start medications, before we start insulin, dietary intervention first. Okay. Second, after dietary intervention is exercise, physical activity. So, before I go to physical activity, mothers, please remember, or future mothers, do not eat for 2. I'm pregnant. I'm allowed to eat for 2. Please remember that. No, you're not allowed to eat for 2. Not even 1.5.
It's a very common misconception.
Yes, that's a misconception. Still, because once you have GDM, the calorie has even, of course, calorie is slightly high, but still it has to be restricted. Yeah. Okay. How much carbohydrate, how much fat, and how much protein. Okay. So following that, exercise, physical activity. Yes, activity has to be continued. Reduce your sedentary, reduce your potato couch. Please go and exercise. Not unless you are contraindicated. If you have heart problem, you have cervical incompetency, right? You have some other issue. when your doctor say, or placenta previa, when your placenta, what do you call that in layman? Placenta is the uri. So if let's say the uri is down, so no, of course, no exercise. But otherwise, not much contraindication, please increase your physical activity. Monitor your sugar. Yeah, the moment you have diabetes in pregnancy or GDM, monitoring is important. Get your glucose to target, and the glucose is really tight. The glucose target, which I will tell in a short while. Medical treatment, yes, metformin, insulin. That's the only medication that's allowed. No other medications allowed. These are the only two. If dietary and exercise is inadequate, sugar start to go up, then we have to start medical therapy. Okay, during the whole pregnancy, monitoring, follow-up is really sometimes every 2 weekly, sometimes monthly. Ultrasound is every 4 weekly. Every month, ultrasound to monitor the fetus. Yeah, to monitor the fetus, to the early pregnancy, mainly you want to rule out whether there's any anomalies to the fetus. Yeah, all right? And they will plan for your delivery. SVD, cesarean section, any hypertension, etc. Okay, so that's how tight the control is. So you have to go to clinic and to the hospital very frequent, my dear. Okay, right.
Every month ultrasound. And is this only for GDM, or does this apply to all pregnancies?
Pregnancy in diabetes in pregnancy and also GDM. So most of the time they will do an early ultrasound, mainly to look out for any fetal abnormalities. They call it detailed ultrasound, the first during the 24 and 28 weeks. Subsequently, it can be 4 weeks to 8 weeks. Yeah, in the developed countries, they usually do the ultrasound every 4 weeks. But in hospital, usually they do 4 to 8 weeks. Yeah.
Okay. Thank you so much, Dr. Masni, on sharing your very valuable and practical information on the management of GDM. Now we have learned so much about GDM. It's time for our second round of giveaway. So in this second round, 3 more lucky audiences will be selected after this live stream session to win CARiNG Cash Vouchers, and that's 50 ringgit CARiNG Cash Vouchers. Yeah, 50
Go
ringgit,
get it.
3 of that.
Go get it. 50 ringgit, huh?
Yeah. Once more, I would like to remind everyone to remember to like the Caring Pharmacy Facebook page, like and share this live stream, and then tag 3 people together with your answer in the comment section, and this increases your chances of walking away with the 50 ringgit CARiNG Cash Vouchers. Okay, so this next question is actually multiple choice. The question is, how to manage gestational diabetes? We have 3 options. Option A, do we consume high carb and sugary meals? Option B, do we do moderate intensity physical activity such as walking, yoga, and swimming? Or option C, do we avoid checking blood glucose levels? The question is how to manage gestational diabetes. Only one of the 2 answers are correct, and it is extremely simple. So can we have that question pinned? Answer A, consume high carb sugary meals. Answer B, moderate intensity physical activity such as walking, yoga, swimming. And answer C, avoid checking blood glucose levels. Is extremely simple. So to the viewers who have joined us halfway, do participate. Answer the question pinned at the comment box below. You stand a chance to win OneTouch Select Plus Simple as well as CARiNG Cash Vouchers, 50 ringgit cash vouchers after this session. So we are almost
Dilhara,
at the end.
they have been listening, Dilhara.
Yeah, I know. You can see the answers, right?
So the answers are
all of them are right. All of you guys stand a chance to win. Okay, we are nearing the end, actually. We have spoken about so much, but now it is time to take on burning questions. So I would have to filter the questions first because I believe, Dr. Masni, you have answered a lot of their questions already.
Yep.
Okay. So Norsia, very much earlier, Norsia has asked us, is gestational diabetes related to age?
the cause of gestational diabetes mainly because of insulin resistant. So the placenta or the placenta produce, but during pregnant, placenta produce few hormones that antagonize the insulin. Yeah, so it's not really comes with age. The risk factor I mentioned just now. Okay, so if you don't have those risk factor, you're not high risk. So if you already have with obesity, with weight gain, with obesity, sedentary lifestyle, so causing your placenta produce the moment you're pregnant, placenta produce these three hormones: HPL, estradiol, and progesterone, and the other hormones. These hormones antagonize whatever insulin in your body.
Okay.
Antagonize. Okay, so what will your body do? It will overcome. It will produce a lot more. That insulin produce a lot more, so that your sugar maintain. Yeah, to be normal. If let's say you have already low insulin in your body, lack of insulin already, so you can't overcome that resistance. So that's where your sugar start to show, to get higher and higher. As your pregnancy progress, if you don't start medication, you don't start dieting, your sugar get higher and higher, because as your pregnancy progress, the placenta will increase in size and produce that hormone, more of that hormone, which is resistant to the insulin. Okay, so the answer is no, it do not come with age. But if you're diabetic, you're not pregnant, as we get older, we are higher risk of getting diabetes. That comes with age. Okay, but if you're not pregnant, that is a yes. If we are pregnant, age is not a risk factor. Yeah.
Thank you so much, Dr. Masni. I hope Nursia has received her answer well. The simple answer is no, but then there are buts. Okay, next question is by Yvonne Liang. Also, very much earlier, she had asked, how many times do we need to do glucose test during pregnancy? I'm sure that's not a very simple answer to this.
Yeah, maybe we can put up that slides. The last, I didn't put it up just now. Maybe the admin can put up the last slide.
Last slide, okay.
If you are on the one that I showed, the glucometer monitor, how frequent to check? Okay, yes, this is the one. Okay, if you are on oral medication, on diet, on diet only, so I would advise maybe about 3 to 4 times only. Yeah, early in the morning, 2 hours after breakfast, or 2 hours after lunch, and 2 hours after dinner. Okay, so that's why it's advisable. Most of the time, I'll tell my the mothers, the expecting mothers, buy that glucometer, buy the strips, yeah, so that you have to monitor yourself. They have to do the monitoring, yeah. Okay, so if let's say they have started metformin, sugar start to go up, we started metformin. So on metformin, still similar, I will still advise them to check about 4 or maybe 5, yeah. The moment the sugar start to go up, diet is not controlled, sugar is getting higher. Okay, we've already started insulin, it will be about 5 to 6 times per day. This is the minimum time. This is the minimum. This is the minimum. 4 times or maybe 5 times is minimum. Sometimes I need patient to do 6 to 7 times. Yeah, which is before and 2 hours after breakfast, before and 2 hours after you've taken your lunch, before and 2 hours after your dinner, and pre-bed, yeah, before you go to bed. Yeah, right? So it can be 6 to 7 times. Yeah, okay, so because we need that sugar to be very tight, narrow. What are the target? Early morning, your sugar should be, if let's say any one of this over here are diabetic during pregnant, sugar in early morning, when fasting before meal, should be 5.3 and below. 2 hours after meal, it should be about 6.4 to 6.7. Yeah? Should not be more, not even 6.8, not even 7. 6.7 on the dot, yeah, on the dot. So that's how tight it has to be. Yeah, right? If you're not controlled, your sugar is haywire, you know the complications already to the mother and also the fetus. Okay, so I answered the question.
Dr. Masni, just now you brought up something very interesting. the target levels.
Mm.
So I would just, if you would, could you repeat the target levels? I'm sure some people would like to take notes. What are the optimal target levels?
So before meals, pre-meals, most of the time at pre-breakfast, it should be 5.3 and below. 5.3 and below. Okay, 2 hours after meal, it should be 6.7 and below, 6.4 to 6.7. Yeah?
Okay. Okay. Very simple targets if you know what to do and how to manage it. Now, just now also you mentioned to buy a glucometer. I would just like to announce to everyone that there are many different types of glucometers out there, and it is not easy for the first time. If you're attempting to use it for the first time, it may not be easy. So if you find that you need help, don't hesitate to walk down over to any caring pharmacy. Go up to the pharmacy counter and ask for help. All caring pharmacists are ever ready to help you manage glucose, manage your blood glucose levels, and also help you help you learn how to use the devices
Use the glucometer.
So you can do home monitoring. Yes, and okay. Okay, so let's move on to the following question. Could we also put up the slides earlier? I'm sure some people would like to screenshot that page on when we should do glucose monitoring. Yes, SMBG, timing of SMBG means self-monitoring blood glucose. Please screenshot this page. This is absolutely important. If you want to understand further, you can rewind on this video, or you can take this to a caring pharmacy and ask the pharmacist to explain. She will be able to explain this as well.
Yeah, most pharmacy, you go, they will explain to you how to use the glucometer. Okay?
Yes.
Right? It's easy to use.
Yes, extremely simple. If you can do it a few times in a day, you can do it forever.
Is it painful? No.
No.
It's not painful because you can adjust the depth of the needle. Yeah, you can adjust. Okay.
Okay. So moving on. Okay, Atika Azil has posted a question to us. Selepas bersalin, bagi mother yang ada GDM, adakah mereka perlu di-screen semula untuk cek blood glucose mereka?
Ya, perlu sangat-sangat. Perlu sebab memang berisiko. So, lepas bersalin, 6 minggu selepas bersalin, go to GP, go to klinik kesihatan ke, go to your private doctors, please check your sugar at 6 weeks after delivery. Okay, so most of the time dia akan check balik sama ada kena may or may not buat balik oral glucose. Kebanyakan masanya mereka prefer pakai oral glucose. Buat balik test tu nak confirm you diabetic or you not diabetic. Yeah, because as I said just now, memang high risk untuk dapat type 2 diabetes selepas GDM. Okay?
Okay. Thank you so much, Dr. Masni, for answering that. Okay, then there is one more question from Aisha. From Aisha Sharifuddin. Doktor, jika seorang ibu yang sudah bersalin, test GDM upper average normal selepas minum air gula. What is the normal values that you should get in your oral glucose test?
OGTT just now. Okay.
OGTT.
This is you are high risk. Okay, you have to go through. You are screen. So kena screen awal. So the moment you datang antenatal, so untuk screen, minum air glucose tu normal. You tak ada GDM. Kalau bawah daripada 5, sebelum minum glucose tu, sugar tu 4.7, 4.8. As long as 5 and below. Satu. Lepas 2 jam, 2 hours after that glucose, it's 7.8 and below. Okay, 7.8 and below. So that's not, itu tak ada, you don't have GDM then. Okay?
Okay, and thank you, Dr. Masni, for that. Very simply put, it should be less than 5 before meals. Am I right? For fasting blood sugar, less than 5. And then after meals, 2 hours, it should be at most at 7.8.
7.8 and below.
Okay. All right. Awesome. Okay, I think that wraps up all the questions we have. We have had some that were already answered. And I would just like to thank everybody right here for their very active participation.
Yeah.
Yeah.
They're still
And
answering.
and all very relevant questions as well. So don't forget, you can still answer the questions I posted earlier. It's pinned at the top of the chat box. Just want to remind you that there are 5 glucose monitors, and then there are 3
Vouchers.
CARiNG 50 ringgit cash vouchers. So that's a total of 8 winners that we will be contacting later on. Thank you everybody for your questions. Very, very interesting questions. Okay, we are actually very much at the end of our live stream tonight. Okay,
finishing. We are finishing?
Yeah.
We are ending? Yep.
We are ending today with our guest speaker, Dr. Masni. She has, Dr. Masni, thank you so much for your treasured information on GDM today.
You're most welcome.
Yeah, very, very informative, even for me myself.
Yep. I hope that's helpful for those future mothers.
Definitely. Remember, everyone, if you have friends or family that were not here, please tell them that the link will always be available in our CARiNG Facebook page. They can always hit the rewind button and watch this all over again. Okay. Dr. Masni, before we end the session, I actually have one very dramatic question for you.
Yes, Dilhara.
If you could have one thing to say to save a woman from gestational diabetes, what would you say? That one last piece of advice.
Please screen. The moment you're positive, if you know you are high risk, do something about yourself to prevent getting diabetes and getting GDM, because prevention is cure, right? That's number 1. And number 2, okay, I have not one, I have 2. If you the moment you're pregnant, you know you're positive already, UPT is positive, the screen as early as possible, screen for diabetes, right? Screen for diabetes as early as possible to prevent complications. So that's 2 actually.
Okay, the last 2 things, screening.
Yes.
Thank you so much for answering my very dramatic question. Thank you, Dr. Masni, for sharing your extensive knowledge on the management of gestational diabetes. I would also like to thank everyone in the audience today.
Yeah.
You guys have been so involved in this, and I really appreciate it. CARiNG appreciates you. Okay, and as for the viewers anticipating the giveaway winner announcement, be sure to keep an eye out on CARiNG's Facebook page. That's where we will be announcing the winners, and it will be very soon. Okay, so once again, thank you for joining us this lovely Thursday evening. Dr. Masni, I'd just like you to wave bye-bye to the camera because we will be going now.
All right.
Okay, say bye. Thank you so much, everyone.
Thank you for
Lovely
listening.
Session today.
Bye-bye.
Bye-bye. See you next time.